Welcome to the Radonc Smart Review GI Cancer series. Today we're really getting into a crucial topic in GI radiation oncology.
ER, rectal cancer part 3.
Exactly. Focusing on the total neoadjuvant therapy revolution, you could call it, and also the huge shifts in DMMR management.
Yeah, this is really designed to give you those high-yield clinical insights, things that are fundamentally changing how we approach some of these really tough rectal cancer cases.
Right. Because in our previous chats, we sort of laid the groundwork, didn't we? Established the basics of neoadjuvant radiation.
We showed that, giving RT before surgery is better for standard risk disease. Better local control, mainly. That's still key for many patients.
Definitely.
Good.
But, and this is the big but, for those patients with the highest risk tumors, the real problem, the thing that drives mortality, it isn't always local failure, is it?
No, it's actually distant metastases. That's the kicker. So our standard approach, great for local control, but it kind of falls short systemically for these high-risk folks, and that's where things really had to change.
Absolutely. This reality, this constant threat of mets spreading beyond the pelvis, it sparked what we're genuinely calling a revolution in care.
It really has.
So our mission today is to properly define total neoadjuvant therapy, TNT, and really understand why we do it, the rationale behind it.
Yep. And we'll break down those blockbuster trials that have completely redefined the standard of care for high-risk rectal cancer. Look at the evidence.
Exactly. Show you why these shifts happen. And then we pivot to something I find incredibly exciting. Game-changing stuff for DMNR tumors.
Deficient mismatch repair.
Yeah.
A whole different biological beast.
Totally. So get ready for some high-yield clinical insights, things you can hopefully use right away.
It's really about pushing beyond just local control, isn't it?
Right.
Fighting the systemic battle right up front changes the whole prognosis.
Okay, so let's anchor this discussion. Let's use a case, a challenging one that sort of shows why TNT became, well, necessary.
Good idea. Makes it concrete.
Right. So imagine you're seeing a 58-year-old man. He presents with a low-lying clinical T4A N2 rectal adenocarcinoma.
Okay, so already high stage. T4A, N2. Low down 2.
Yeah. And on his staging MRI, it's a big tumor pushing through the muscle wall, maybe into nearby structures. And critically, it's threatening the circumferential resection margin, the CRM.
Oof. CRM threatened. That's a big red flag for surgery, right? Higher risk of positive margin.
Exactly. Plus, multiple enlarged pararectal nodes. Looks like N2 disease.
Significant nodal burden.
This is what we sometimes call ugly risk rectal cancer in clinic.
Yeah, that term fits. It's a formidable presentation. Really screams out for the most comprehensive approach we've got.
So for a patient like this one, with all these aggressive features, just doing standard neoadjuvant chemoradiation and then surgery, it's just not enough, is it?
No, it's inadequate. I mean, it works for lower risk cases, but here, the risk of distant failure, those micromets that are already there but we can't see, it's just too high.
Prohibitively high.
Yeah. Exactly. And that's precisely where TNT comes in. It's strategically superior here. The core idea is actually pretty simple but powerful.
Which is?
You front load the entire course of systemic chemotherapy, give it all up front, before they have that major pelvic surgery, the TME.
So it's not just shuffling the order.
Not at all. It's about maximizing the patient's ability to actually get the full chemo dose and, crucially, hitting those systemic cancer cells early and hard.
And the why behind TNT, the rationale. I find it helpful to think of it as the 3 C's of TNT. Makes it stick.
Okay, I like mnemonics. Let's hear the 3 C's.
All right. First C, and maybe the most important, combating distant metastases. Early eradication of micromets.
Right. Because we knew for years the main killer in these high-risk cases wasn't local recurrence, it was mets.
Exactly. TNT hits this head-on. Systemic therapy when the micrometastatic burden is lowest, theoretically, before surgery might spread things or before the patient gets too run down post-op.
Hit those circulating cells before they set up shop elsewhere. Makes sense. What's the second C?
Second C, complete response and downstaging.
Ah, so better tumor shrinkage.
Way better. By giving more chemo up front, maybe more potent chemo too, you get much higher rates of pathologic complete response PCR. No cancer left at surgery.
Which is a fantastic prognostic sign.
Absolutely. And better downstaging overall, which can mean maybe a better chance at sphincter preservation for those low tumors, right? Avoiding a permanent bag. Huge quality of life impact.
Definitely. Okay, third C.
Third C is chemotherapy completion. This one's super practical.
How so?
Well, think about it. A TME, that's major surgery. Patients are recovering, maybe have pain, nutrition issues, they're weak.
Yeah, giving adjuvant chemo after that can be tough. Lots of dose reductions, delays.
Yeah,
Sometimes they just can't finish it.
exactly. But if you give the bulk of the chemo up front, when they're generally stronger, they tolerate it better, you get higher completion rates for the full intended regimen.
So they actually receive the treatment we want them to get. That's critical.
Totally. So for our 58-year-old guy, T4N2, threatened margin, ugly risk.
TNT is the undisputed standard of care now. No question if we should use it for him.
Right. The debate now is which TNT strategy is best for that specific patient.
And that's where the field is really focused now. Which sequence, which drugs?
And what a fascinating debate. Because
Yeah.
we have two major practice-changing trials that really define the landscape.
Yeah.
Gave us two distinct, effective pathways.
Let's start with RAPIDO then.
Okay, Rapido. This one really championed the consolidation approach.
Okay.
RT first, then chemo.
Right. RAPIDO was big. International, randomized, over 900 high-risk patients.
And the arms?
Standard arm was long-course chemoradiation, the usual 50 gray over 5 weeks with chemo, then TME surgery.
The old standard for neoadjuvant.
Pretty much.
Yeah.
But the experimental TNT arm was different. Started with short-course RT, just 25 gray in 5 fractions, 1 week.
Quick and potent.
Yeah. Followed by 6 cycles of consolidation, chemo, KPOX, or FOL, Fallbox, standard stuff, and then TME surgery.
So RT, then a big block of chemo, then surgery. Consolidation.
Exactly. And the primary endpoint was disease-related treatment failure. So local recurrence, distant mets, cancer deaths.
The whole package. And the result.
TNT arm was superior, clearly better. And here's the absolute key finding, the thing that really shifted thinking.
Which was?
The superiority was almost entirely driven by reducing distant metastases. Went from like 28% down to 24%, significant drop, hitting that main driver of mortality we talked about.
Oh, wow. Directly addressing the biggest problem.
Precisely. Plus, the PCR rate doubled, 28% in the TNT arm versus 14% standard. Huge improvement in wiping out the tumor locally before surgery.
That really solidified the TNT concept, didn't it?
Yep.
Early systemic therapy works.
It did, but there's always a but in medicine, right?
Usually. What was the catch with Rapido?
The 5-year update showed a slight trade-off. While systemic control was way better, the short-course RT arm had a slightly higher rate of local recurrence, about 10% versus 6%.
Okay. So better systemically, slightly worse locally.
Yeah. Not a deal breaker necessarily, but something you have to consider, especially with really borderline tumors or close margins. Still, Rapido established short-course RT plus consolidation chemo as a new standard for high-risk patients, especially good for hitting distant disease hard.
Okay, so Rapido gives us one strong pathway. Short RT first. But you mentioned another major trial, didn't you? PRODIGE 23. Yeah. How did that one approach TNT?
Right. PRODIGE 23, French study, they looked at a different sequence. Induction approach, chemo first, then RT.
So flipping the Rapido order.
Exactly.
Yeah.
They also randomized patients. Control arm got standard preoperative long-course chemo, then TME, then adjuvant chemo. Pretty standard at the time.
And the TNT arm.
Started with 3 months of induction chemo, and they used a really potent regimen, MFOL HAX-RRI.
FO, Elf-Tox, plus irinotecan. That's heavy duty. Usually used for metastatic disease, right?
Yeah, it's aggressive. Applying it up front and locally advanced was a bold move. After that chemo blast, then they got standard long-course chemo, then TME, then a shorter course of adjuvant chemo.
Okay, so hit hard with chemo first, then the standard chemo, then surgery, induction.
That's the one.
And the results. How did PRODIGE 23 stack up?
Just as impactful, really. Maybe even more so in some ways. The intensified TNT approach was the clear winner.
How do they measure that?
3-year disease-free survival was significantly better. 76% in the TNT arm versus 69% standard.
7% absolute improvement. That's clinically meaningful. Patients living longer without recurrence.
Definitely. And like Rapido, PCR rate more than doubled. Jumped from 12% standard to 28% with TNT.
Wow, same PCR jump as Rapido, 28%.
Yep. But here's the crucial difference from Rapido.
Okay.
No penalty in local control. Unlike Rapido's short-course finding, the long-course chemo after induction chemo in PRODIGE 23 maintained excellent local control rates.
So you got the great systemic benefit and kept the solid local control.
Exactly. Which makes it a really robust option, especially if you have very bulky local disease or really need that maximum local effect from the long-course radiation.
Okay, this is fascinating. So now we have two proven successful TNT models. Rapido, short RT consolidation chemosurgery, PRODIGE 23, induction chemo long RT surgery.
Right. Both valid standards of care for high-risk disease.
Which brings us to a really important clinical question. If you have a patient, and maybe their big goal, or your goal for them, is organ preservation, trying to avoid the TME surgery altogether, which sequence is better for that?
Ah, yes, the organ preservation question. That's where the OPRA trial comes in. Absolutely crucial guidance here.
OPR, okay, what did it do?
OPR was specifically designed to answer that, induction versus consolidation, which is better for achieving organ preservation for maximizing the chance of a watch-and-wait approach.
So, directly comparing the sequences for TME avoidance.
Precisely. They randomized patients who were potential watch-and-wait candidates to either induction chemo then chemort or consolidation chemort then chemo. Primary goal, TME-free survival, rate of avoiding surgery.
And the answer? Did sequence matter?
It mattered. Big time. The results were really clear. 3-year TME-free survival. The organ preservation rate was significantly higher in the consolidation arm. The RT first arm,
How much higher?
53% versus 41%.
Wow, 53 versus 41. That's a big difference.
Huge. It tells us that giving radiation first, letting it work its magic, consolidating its effect before the chemo, that gives a better shot at getting that complete clinical response needed for watch and wait.
So the takeaway is pretty clear then.
Absolutely. If the primary goal is maximizing the chance of organ preservation, avoiding that TME, the evidence from OPRA strongly favors a consolidation approach. Radiation first.
That's such a key point for counseling patients, isn't it? It really changes the conversation when non-operative management is on the table.
Completely. It gives us solid data to guide that shared decision-making.
Okay, let's switch gears now. Let's talk about something that feels like, well, a true paradigm shift. A complete change in how we think about a certain type of rectal cancer.
You mean DMMR tumors?
Exactly. Deficient mismatch repair. It's like, imagine oncology has this really tough, locked door, right? For years, we've used sledgehammers, chemo, or chisels radiation, trying to force it open.
Yeah, brute force sometimes.
But for this small subset of doors, the DMMR ones, suddenly we found. It's like we found the perfectly cut master key. That's the kind of revolution we're talking about here.
That's a great analogy. It really captures it. Because we're talking about maybe 5–10% of rectal cancers.
Small subset, but important.
Critically important. They have this faulty DNA mismatch repair system. Basically, their DNA spell checker is broken.
So errors build up as the cells divide.
Loads of errors. High mutational burden. This means the cancer cells express tons of abnormal proteins on their surface neoantigens.
Okay, so they look really weird to the immune system.
Exactly. That's the key. Historically, these DMMR tumors, they responded poorly to standard chemo. It was a real challenge.
Right, often worse outcomes.
But because they look so weird, because of all those neoantigens, they are incredibly, exquisitely sensitive to immunotherapy, checkpoint inhibitors.
Ah, so you unleash the immune system and it sees these funky cells and attacks them.
That's the master key, that biological vulnerability.
And this wasn't just theoretical, right? There was that incredible study from Memorial Sloan Kettering, published in the New England Journal in 2022.
Oh yeah, the dostarlimab study. Absolutely groundbreaking. Maybe unbelievable is a better word.
What do they do?
Phase 2 study. Took patients with stage 2 or 3 DMMR rectal cancer. And the treatment, this is the revolutionary part, was just 6 months of neoadjuvant immunotherapy, the PD-1 inhibitor dostarlimab.
Okay, just immunotherapy. What about chemo? Radiation?
None. Zero chemo. Zero radiation. Just the immunotherapy drug.
Wow. Okay, and the results?
Miraculous isn't too strong a word. Every single patient in the trial, 100% had a clinical complete response.
Wait, say that again, 100%.
100%. Complete clinical response. Tumors vanished. On scans, on scope, on exam. Gone.
That's unheard of, especially for locally advanced cancer that usually needs chemo, radiation, and surgery.
Exactly. It sent shockwaves. I remember reading it and thinking, is this real? Had to double check. Felt like science fiction, honestly.
I bet. So this truly is a paradigm shift. For these DMMR locally advanced rectal cancers, immunotherapy alone is becoming the new standard.
It is. It's moving incredibly fast into practice. It forces us to ask, should we be doing universal DMMR testing for all rectal cancers at diagnosis now?
It seems like you'd have to, right? Given the implications.
I think so, because identifying that 5–10% changes everything for them, potentially avoids chemo, radiation, surgery.
And it makes you think, what other cancers might have similar master key vulnerabilities if we just find them.
Exactly. It's pushing towards truly personalized medicine based on tumor biology, moving beyond one size fits all.
Okay, wow. So much ground covered. Let's try and synthesize. Let's pull out some key clinical pearls from all this, the stuff you really need to take away.
Good idea. High yield points. Pearl number 1.
For high-risk rectal cancer, that ugly risk group, TNT, total neoadjuvant therapy, giving all the systemic chemo before surgery. That's the new standard, period.
Yep. Prioritize systemic control up front. Okay, pearl number 2.
The RAPIDO trial gives us that short-course RT pathway within TNT. Great for systemic control, reducing distant mets, but maybe a slight trade-off on local control, a powerful, time-efficient option.
Right. Pearl number 3. PRODIGE 23 offers the long-course RT pathway, usually with more potent induction chemo like MFO-Ulfax-IRI. Improves disease-free survival without sacrificing local control. Another excellent TNT choice.
Pearl number 4, organ preservation. If that's the main goal, the OPR trial gives clear guidance.
What's the guidance?
Deliver radiation first. The consolidation approach gives the best chance of achieving that complete clinical response needed for watch and wait. Crucial for patient counseling.
Got it. RT first for organ preservation focus. And pearl number 5, the big one.
The game changer. For dMMR tumors, especially locally advanced rectal, neoadjuvant immunotherapy alone.
It's changed everything. Complete responses without chemo or radiation in many cases. Monumental shift. Requires universal testing.
Okay, ready for a quick board blitz? Test ourselves on these revolutionary strategies.
Let's do it. I'm ready. Hit me.
All right, case 1, 60-year-old man. Clinical T4A rectal cancer, 7 centimeters from anal verge. MRI shows tumor threatening the mesorectal fascia.
Yeah.
Multiple enlarged pararectal nodes, looks like N2. What's the most appropriate initial treatment? A, upfront TME, then adjuvant FO-LFOX. B, standard long-course chemo, then TME. C, total neoadjuvant therapy with either RAPIDO or PRODIGE 23 regimen. D, short-course RAOT, then immediate surgery.
Okay, T4A, N2, threatened margin. That's textbook ugly risk. So standard chemo alone, B, isn't enough systemically. Upfront surgery, A, is risky with that margin and ignores systemic disease.
Right.
Short course RT, then immediate surgery, D, misses the whole point of neoadjuvant systemic therapy and downstaging. Has to be C. TNT is the standard for this high-risk patient. Maximize systemic control, maximize chance of R0 resection.
Excellent reasoning. C it is. Okay, case 2. In the PRODIGE 23 trial, what was the approximate 3-year disease-free survival for patients getting the TNT arm, the neoadjuvant FO-LFOX-IRI, then chemo surgery adjuvant chemo? A, 56%, B, 66%, C, 76%, D, 86%.
PRODIGE 23. Primary endpoint was 3-year DFS. The TNT arm showed that significant improvement over standard care. I remember it was a 7% absolute difference. Standard was 69. So TNT arm must be C, 76%.
Spot on, C, 76%. Okay, final question. Case 3, 52-year-old woman. Clinical T3N1 rectal cancer. She's very interested in avoiding surgery if possible. Asks you which TNT sequence gives her the best shot at a complete response for watch and wait. Based on OPERA, what do you recommend? Induction sequence, chemo first. B, consolidation sequence, chemo first. C, sequence doesn't matter for organ preservation. D, TNT isn't appropriate if considering organ preservation.
Ah, the OPRA question. Designed specifically for this, patient wants organ preservation. OPRA showed sequence definitely matters, so C is wrong. And TNT is the way to maximize organ preservation chances, so D is wrong. OPRA found the consolidation sequence, RT first, gave significantly higher TME-free survival. So got to be B, consolidation, tumor first.
Perfect. B is the answer, based squarely on OPRA. Great job.
Thanks. Those trials really do guide our choices now.
They absolutely do. So we've broken down these 2 successful TNT models, RAPIDO and PRODIGE 23. One short course RT, consolidation, the other long course RT, induction. But how do we choose between them if the patient isn't primarily focused on organ preservation? What tilts the balance in clinic?
Yeah, that's a great practical question. It often comes down to a nuanced discussion, usually in a tumor board. Both are valid, right? But patient factors matter hugely.
Like what?
Performance status, comorbidities, that MFO-FOXCR in a PRODIGE 23, it's tough. Higher toxicity, diarrhea, neutropenia, maybe not great for an older, frailer patient.
So for them, maybe RAPIDO's approach is more tolerable up front.
Potentially, yeah. The short RT is quick. And maybe you use FO-HOX or CAPOX consolidation, which might be a bit gentler than FO-HOX-IRI. Tolerance is key.
Makes sense. What about tumor factors, beyond just high risk?
Definitely. If you have really bulky disease, maybe lots of vascular invasion, You might lean towards Prodigy 23 for that maximum systemic punch from MFO off GIRI right away. Hit those potential nets hard.
Okay. What if local control is the biggest worry, like a really threatened margin where every millimeter counts?
Then maybe you favor Prodigy 23 again, but this time for the long-course radiation component. We know long course gives excellent local control, maybe slightly better than Rapido short course based on that 5-year data. It's that balance against systemic versus local needs.
It's complex. And then there's the whole DMMR story, which isn't really a controversy anymore, is it?
No, it's just a monumental advance. It really highlights how fast things are moving, how understanding the biology changes everything.
It really does. Forces us to test everyone, changes the entire treatment plan for that subset. Transformative.
It is, and it makes you wonder what's next, right? What other biological markers will unlock new, better, less toxic therapies?
Okay, let's quickly summarize the absolute key takeaways then for high-risk rectal cancer.
Deliver all systemic chemotherapy before surgery. TNT is the standard. Target systemic disease early.
Rapido gives us a short-course RT pathway. Great for systemic control, maybe a slight local control trade-off.
Prodigy 23 offers a long-course RT pathway with potent chemo, improves DFS without compromising local control. Another solid option.
And if organ preservation is the main goal.
OPRA says, radiation first. Consolidation approach maximizes the chance of avoiding surgery.
And finally, for that crucial DMMR subset.
Neoadjuvant immunotherapy has changed the game. Complete responses, often without chemo or radiation. Test for it.
Which really makes you think, as you said, what other GI cancers, what other tumor types might benefit from these kinds of targeted immunotherapy approaches down the road?
Exactly. Something profound to consider as you keep learning and growing in this field. It's an exciting time.
It really is. Well, this concludes our comprehensive session on these revolutionary rectal cancer strategies.
For our complete practice oral boards and detailed show notes, remember to visit radoncSmartLearn.com. That's radoncSmartLearn.com. And be sure to subscribe to Radonc Smart Review for our next session. We'll be putting all this into practice treatment planning, re-irradiation workshop. Should be good.
Looking forward to it. Thanks for tuning in, everyone.